Idea how many questions for analogy? No. Okay. One. For what? For? Okay, next. Okay, one OSCE, one SPQ, and for your SBA? Okay, two, that's right. So for analogy, you have two SBAs, one OSCE and one SPQ, right? So your OSCE will be interactive session with the examiners. So you'll be given a radiograph and you need to comment on the radiograph. So basically, when you are dealing with radiograph, in OSCE, first introduce yourself and just and show your manners and professionalism. When you see the radiograph, relax, don't rush. Take 30 seconds, 1 minute to examine properly the radiograph, and then comment the radiograph as professional as possible. You need to state the examination, what kind of radiograph, is it chest radiograph, is it abdomen radiograph, is it CT brain or anything given to you, and its projection, if it's radiograph, is it lateral, is it oblique, is it anterior posterior, is it posterior anterior projection, and then if it's a chest radiograph, I will recommend you to comment on the quality of the radiograph, on the collimation, on the, because you are being taught how to comment on the chest radiograph, isn't it? Yeah. On the chest proper. If you are given outside the chest and bone or abdomen, just show some professionalism before you go into the findings of the radiograph. And then, so first and foremost, relax. Don't be afraid. Take a few seconds or 30 seconds, 1 minute to examine the radiograph and then start to comment on findings. So this is what we expect. Don't worry, your radiograph will be very straightforward. It's not like ours. So comment on the findings. What are the positive findings? Whether you can say whether there is a pneumothorax or there is air in between the dura, for example, there is tension in pneumothorax. If you partials, for example, you given the pediatric chest radiograph, comment on the size of the heart and large. How does the shape looks like? Is it snowman appearance? Egg on string appearance, for example. This is for example. Also comment on the negative that you think important. If chest is normal, no pneumothorax or anything, just comment no pneumothorax, no pleural effusion. I think you can appreciate that, right? Very simple pneumothorax, for example. This is just for example. So you think negative findings that is important. When you have become a house officer or resident later in the future, that you need to consider in your management, related to the radiograph. Okay, and then finally you offer your diagnosis. This is a tension pneumothorax, and then you would be the best if you can offer your management, not as in you are a consultant, but as in you are a house officer. For example, I will inform my superior regarding the radiograph. If possible, I would like to do, for example, if the patient has a tension pneumothorax, I would like to do okay. And then to comment on the not very good sensitive.
Thoracocentesis lah. Needle thoracocentesis.
A very important emergency. That's it. That's how you comment on the radiograph. And then we will give you the marks based on your comments on the radiograph and your professionalism. Okay. Any question on that? Basically, your OSCE and your SBQ more or less the same. More or less the same. SBQ, you will write it down on the paper. And as in OSCE, you will convey the message to the examiner as in you are the house officer or resident. Okay, any questions? Yes, it's part of it. No. Takut kan? Senang je dia. Yes. 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 There will be a picture of radiograph. Will be given the scenario, and you need to answer based on the question, based on what we ask you. Possible. It's possible. Very obvious.
Itulah sebab
Radiograph.
tak.
Okay. For that detail, there will be a radiograph, but it will be the same as other. We have our own 10 questions. It's not as in we are. Or your question integrated with other question, other posting. No, we are standalone. We are standalone question. One SPQ. Other posting, for example, surgery or orthopedic, they may have their own radiograph, which is not related to us. For that, I cannot comment much for that. Any other question? No. Okay. I think Dr. Azudin has covered a lot previously. So I'm just going to go through a few of the pictures. So can I have volunteers to comment on the, try to practice how to comment on radiograph? Huh? Can I have any volunteer? The script I've given you previously, this is how you, more or less how you approach radiograph. And for chest, maybe a bit extra, you comment on the quality of radiograph.
Interior pasti ni AP view.
Any volunteers?
PA view.
Yes.
Dia tengok scapula dia, scapula tak clavicle dia.
Okay, when you say there is adequate approach, evidence by, that will be. Okay, alright, continue. For our level, this is not an acceptable radiograph. For our level, that's okay. I think for as in you show your effort to comment on that. I think that's good enough. Okay, continue. Okay, right. Any negative relevant?
Right side any difference?
Then pneumothorax, is there any infection? And then you have pneumonia, and then also red fissure,
Yes, I will.
edema. And then you need to comment on your radiograph. Right. Okay, your diagnosis? Correct. So that's very specific, but I expect you to just say this is a case of academically possible, right? Very good. You have any suggestion for this question? Any further investigation? Next. The volunteer?
Langit besar ke?
I think you have been taught about the mnemonics. There is a few mnemonics. You were taught about ABCD. Good. Okay. There is four main things. First, you need to assess the exposure, as you mentioned. How do you assess exposure? Is basically you assess the vertebral spine, the thoracic spine. So behind the heart, it should be just barely visible, not too much. And then it's overexposure. This is underexposure. Underexposure. Then you cannot see the vertebral body at all. And then you comment on the collimation. You know about collimation? Yes.
No.
So when you are getting a radiograph, you need to see what you want to see. You cannot cut the thing that is important in the radiograph. That's what we call collimation. When you want to see the lungs field, then all the lungs should be visualized. That's what we call collimation. It cannot be too wide and it cannot be too narrow. So for chest radiograph, you want to see the chest. So all the lungs field should be visualized because some radiograph they cut just above the diaphragm. Probably the cassette is not too big when you take the radiograph and you shoot the radiograph, or the patient is too big. It cannot fit into the cassette. That can be. That's collimation. So you want to see what you want to see. Chest radiograph, you need to see the chest. So in this case, the collimation is good because it included all the lungs parts, and we can see at the costophrenic angle. Also, we can assess. We can see the diaphragm. We don't need to see much of the shoulder because if you want to assess the shoulder, we need to do the shoulder radiograph. That's the sense of collimation. And then you need to see the inspiration and expiration, whether it's adequate or not. So you need to count it. Anterior, how many?
6.
6 anterior. Posterior? 8, 10 to 11. 9 to 10. Okay, 9 to 10 will be good enough. And the 6 to 7 will be good enough. More than that or less than that? More than that, you can see 11. What do you call that? Hyperinflation. Okay. Less than that? Under inspiration. And then you assess this patient. Then we have assessed the exposure, assess the collimation, assess the inspiration and expiration. We need to see whether the projection, whether this is PA or AP. Okay. So most commonly, healthy patient who can stand up will be PA. Patient very sick, you see all the intubation tube, everything, usually is taken in supine or AP position, anterior posterior. So in your exam, please state posterior anterior or anterior posterior. Don't use AP or PA short form. Please use the full name of anything. Don't use short form for the purpose of exam. Alright. Clear? Clear? Not clear? Any question? Alright. Next. You just keep part the exposure, everything. You can practice on your own for that. Just go straight to the findings. Wah, ambil gambar semua orang. Pasal exam ni.
This is an AP view of the chest.
Buat sikit kan? Good. Good. So which Right side, which zone, you say?
Middle zone.
Middle zone. How you divide the zone?
Tengok horizontal apa dia nama tu.
By the, how do you, ada orang ajar ke? Anybody taught you? By the ribs. How they taught you how to divide the zone? Okay. Boleh nggak semua orang? Can I read here? No. Oh, okay. Ini got less, got less.
I actually learned this because of radiography I take for clinical life. So for apical to second rib is upper zone, if I'm mistaken. Second to fourth is mid zone, while anteriorly, I'm talking about anteriorly. The four to six is the lower zone.
Any other person has another technique to divide? Tak apalah, we are in consensus. So that's good. You say there is a already cavitation with fluid level. Okay, good. So what is your impression on this? Lung abscess. Okay, very good. Any other modality that you want to do? Let I hope that further help you. Okay, CT scan will be more appropriate, the next step of management.
Tengok extensions.
Buruk dengan apa? Okay. Apa nak cakap lah? Okay. Ha? Hyper? Hyperinflation. This is a very bad thing. Hyperinflation. This is hypertension. What kind of disease?
COPD.
Alright. So any suggestion for this patient? Yes.
Bronchodilator. Stop smoking. Orang fashion.
Next.
Ya demo.
This is very important now. This is very common, but this is usually missed in emergency department and can cause the patient a mortality. Siapa boleh jawab ni?
Ni cik bronchiolitis ke?
How many international students we have? 2 international students? 3? 6 then? Not around. Right. Okay, let me give this scenario. This is a 10 years old patient. 10 years old. This is a pediatric. Pediatric kan, you can see the epiphysis not fused yet. This is how you see the radiograph. See the physis. This is pediatric patient. Can you appreciate that? Cannot. Fused yet. So this is a pediatric patient. Epiphysis still present. So this is a 10 years old patient. Came to you. You are the ED husband, 6 posting at the time. So this patient first came to you, 10 years old. Her mother said last thing that 5 years old, more appropriate. Last thing she saw, his boy was playing with Lego.
Foreign body aspiration ke? Tapi kalau Lego patutnya nampak. Aku tak tahu. Sebab dia sekarang dia transparent. Oh, plastik.
So what's the first thing that you notice in this
Tak tahu
radiograph?
lah. Sebenarnya the first thing that you need to do is
Yes,
take care.
opacity is not the same. So always be suspicious. In the pediatric patient, when you see there is a different opacity, there's a few things. Okay, different opacity can be normal in like 2% of human. Can be caused by absence of the pectoralis muscle. pollen syndrome. Pollen syndrome. This is normal,
Policy.
but it's very rare. Not to say it's very, very, very super rare. There is, but I think it's about 1% or less than that. So, but if the question came to you in emergency, you see there is different in opacity. The first thing, pediatric question somehow, first thing come to your mind is foreign body ingestion. The foreign body stuck into the which side?
Physical injection.
Sudah.
Tapi kalau foreign body aspiration dah masuk left ke right.
Pandai.
The opposite.
Betul. So it will be to the commonly to the right because of the anatomical position.
Right,
Correct, correct.
yes.
Pernah mahu kali? Boleh jadi radiologist. Right. So when you see there is hyperlucency on that side, why is it hyperlucency? Because the foreign body become
Dislodged.
ball valve effect. You can suck in the air, it cannot go out. So every time you breathe in,
Dia stay and
the air cannot go out.
residual.
So it can become hyper-expanded, it become hyperlucent compared to the contralateral side. Does it make sense?
Hell yeah.
Right. Yeah, the depressed one. This is not the severe form. Right, next.
Ya, game.
This is very common. No.
Nobody maunya.
Tak ada lah, ambil gambar. Semua ambil gambar. Ambil gambar saya ke? Okay, give me the findings first. Describe the findings before you give the diagnosis. Hyperlucency,
Tak ada.
homogeneous opacity, okay, correct?
Over the right zone, the right middle zone.
Alright, that middle zone. What? Okay, alright.
Tenting of the
Evidence
hemidiaphragm tu.
as well.
Tu tenting ke tak tu?
Why do you say lung collapse?
Tenting of the hemidiaphragm.
The diaphragm.
Oh,
Elevation. Okay, elevation diaphragm. Okay.
Is it
So when you describe the
cardiac
diagram, is either opacity or is either lucency. Is it homogeneous, heterogeneous? Is it like a cotton ball appearance opacity, as in the cannonball metastasis? That's how you describe. Is it in the interstitial opacity within the interstitial tissue, in case of pulmonary edema, for example? So this is homogeneous or homogeneous opacity. And the middle zone, which likely involving which lobe? Middle lobe. That's evidence of collapse as well, evidenced by the elevation of the left hemidiaphragm. So what do you think this is? This is not pleural effusion, no pneumothorax.
pneumonia. Kot.
See, terus saya bagi. This is most likely what type of pneumonia? Lobar pneumonia, because it involves middle lobe. Right. Okay, correct.
Ya. Meniscus sign
Okay, apa ni? Apa jawab ni? Efficient. Beside?
right side.
Why we say efficient?
Meniscus sign.
What sign?
Meniscus sign.
Meniscus sign. This is what we expected you to say in your. We know you know,
You don't.
but this is what we expect you to say in your exams. This kind of things. Please, second.
Besar.
Right, this.
Oh.
Normal.
Kau pun dia ni nanti.
Mak kan tak faham pun dia. Where? Pleural effusion. Pericardial effusion.
Costophenia
When there
angle.
is pericardial effusion, so what fills the effusion is fluid. So how fluid appears in your diagram? Opaque, really opaque, like the all consolidation that you see. Pneumopericardium. So how do you describe that? Very slow. sign. Just a plain, don't complicate things. What you see is a lucency, pericardial lucency. So this is likely a pneumo. Any other negative findings you want to say? Pericardial effusion. Okay, then you see this pneumothorax. So, alright. Have you ever heard of Bohe syndrome? Never mind.
Holy crap, no.
Never mind. Bohe syndrome is actually when you're recurrent forced vomiting. Forced vomiting can lacerate part of your esophagus, and the air will be trapped inside. That's why. Never mind. This one very easy. Okay. Predominantly.
Right lung.
Your right lung. Predominantly again. Is it peripheral? Is it perihilar? Is it superior? The apical? Is it perihilar? Parietal perihilar opacity. Apa lagi? Positive findings? Cardiomegaly, okay.
Tak ada venting, posterior angle ada.
Enlargement of the arch of the aorta. Okay. So, this is?
Ada ECG monitoring juga.
Secondary to? You know that pneumonia can be caused by cardiac and non-cardiac cause. Tahu kan?
Pulmonary edema secondary tu
There is cardiac cause of pneumonia. There is non-cardiac pulmonary edema as well, especially in acute patient in ICU. So they can get pulmonary edema as well, but that's non-cardiac pulmonary edema. Okay.
It makes a lot of sense about the engine.
Alright, this is pneumothorax is not enough. This is a tension pneumothorax. So what's the positive findings?
Lepas tu air under apa? Air under diaphragm kan?
Okay. That's you need to. That's what we expect from you. And then this is some emergency. We want you to know the immediate management. This is
fracture of the rib.
Heterogeneous.
Bukan. Right side.
Right. Any cavitation that you can see? Alright, there's some sort of acute level that you can see. Possible.
Wow. Okay.
Right, any pneumothorax? Nah? Ada pneumothorax tak? Jangan reka. There's pneumothorax. So this is likely tuberculosis in our setting. Why? TB? Commonly apa sebab TB in Malaysia can be anywhere, uniquely, especially in Sabah Sarawak. Okay, next. Advisory tunjuk dah lah ni. This kind of cases.
Yeah.
Haila. Mana Haila? Haila kat mana?
Aortic dissection. Ada aortic arch.
Mediastinum. No. Before you jump to the name, you describe. First. Okay, there is widening of the mediastinum. So when there is widening of the mediastinum, what structure up there? It can be
Aorta.
It can be aorta. It can be lymph node. it can be mass, it can be timers, it can be everything. So before you jump to your aortic favorite ruptured aortic aneurysm or everything, you need to examine the radiograph. So before you jump to the conclusion, you need to have a few differentials in your mind. It can be nodes, it can be enlarged timers, it can be aortic aneurysm. I think Dr. Aizudin covered how to assess the ruptured aneurysm, right? Ruptured aortic aneurysm. Okay, so I won't touch on that. So this is a wider mediastinum. You can just give a few differential. As I said, it can be lymphoma, it can be teratoma, fortis. Nothing of fortis. In a wider mediastinum. It can be teratoma, it can be thymoma, it can be terrible lymphoma. Okay, any question? Teratoma can. That's sort of diagnostic technique you consider. Right. So, 20 years old involved in MPA. So, what you can see?
Hyperinflated lang.
Pneumothorax. Hah? Why doktor jawapan? Hah? Multiple pula I give you the history. 20 years old, involved in MBA. Pneumothorax, one thing pneumothorax. Open pneumothorax. Hah? Kuat sikit. Kamu jawab dulu.
Diaphragmatic rupture.
Oh shit, bau.
Belum sakit. So you can see that it's opacity there. Opacity at the left, most of the left hemithorax. Left hemithorax with presence of Haustra. This is likely presence of large bowel in the left hemithorax. In case of MGA, I think this is most likely structured left hemidiaphragm. Itu, that will get stuck. So I would like to refer this case to surgery. She said don't do this.
Nabi maknanya bawal dia ni termasuk dalam.
This is all the rhythm that we need to master before you get. This is very not.
So basically dia nanti keluar cek saya dapat MRI ke apa. MRI way apa MRI brain.
To be a good movement. It's straightforward, but you can see there is a
Foreign body.
There is a opacity.
There is an opacity in
So always describe methodology.
clamshell ke? Benda tu
Always describe first before you offer your final diagnosis. There is opacity in the
Yes.
possible in the stomach. So most likely ingested foreign body. Right. Nampak?
Apa dia ni? Apa yang itu? Dekat itu. Oh, surgical emphysema. Tapi kalau surgical emphysema dia kan tunjuk chest kan. Itu macam
There is this is an abdomen radiograph with at the erect position. There is a presence of dilated bowel. Itu yang tak kena.
Toxic megacolon ni. Yes.
There is a presence of stool at the back material and the lower right quadrant, lower left quadrant, and also right upper quadrant, and also left lower quadrant.
Ya. Rina stone.
Call it DPSC. So
What the heck?
whoever during my class I always say when you are looking at the abdominal graph, there's a few things you see. First is assess the bowel, whether the bowel is dilated or not. So what the measurement of the bowel? 369. 3 for? 3 for small bowel. 6 for? Large bowel. 9 for? Thicker. Okay. First assess for that. Is there any bowel, small or large bowel dilatation? If there is no large or small bowel dilatation, look for any evidence of stone, calcification, radiographic stone, regardless in the kidneys, regardless in the GB area. And then look for any evidence of abnormal opacity. There is a mass, for example, in a huge fibroid, you can see the huge mass at the pelvic region, displacing the bowel superiorly. And then look at the extra things, for example, the bones and everything. There's 4 things you need to look at the radiograph. Diagnosis. Describe or describe? Siapa nak describe? Volunteer. Examination of the large bowel evidence by presence of ulcer. Okay, good. Alright. What are the complications of the dilatation looking for? Perforation. Any evidence of perforation?
Macam tak ada.
There's a few signs of pneumoperitoneum. When you can see the air at the diaphragm or the dolphin leaping sign or whatever. What else you can assess? You can see the regular sign. A regular sign is double density of the wall. There's air in between the bowel wall. Any evidence of inflammation?
Yes.
Inflammation. Any evidence of inflammation?
Patient ni scoliosis kan? Kenapa spine dia macam tu?
The bowel wall. Thickening of the
Spine dia.
cell which will represent the thumb printing sign.
Thumb printing sign.
No. So dorsal looks very thin, right? The bowel wall also doesn't look thick. So this is a case of
Toxic megacolon.
no. A case of large bowel obstruction. Describe what you can see signs.
Dolphin leaping sign. Tu ada right left.
And for next question, describe.